If you found yourself here, you're probably one of my friends or mentors, and you know what I'm doing. But in case that's not what happened, and you just stumbled upon this, let me explain. This is the first video in a series I'm calling Building a Clinic. I've been obsessed with musculoskeletal health. How does someone that might be having pain or just something going on with them that has to do with your bones, joints, muscles, and your nervous system that controls it, really navigate the healthcare system? And so I'm talking to clinicians, researchers, startup founders, and just people passionate about this space to answer that question. Today I talked to Dr. James Leonard, who is probably one of the most genuine people I've met so far in this exploration. Everyone else I've met is extremely lovely, but hanging out with James, I know that this is a guy I'm probably going to be friends with for a while. So hope you enjoy this winding conversation. I'll put notes in the description to click around. Yeah, let's get to it.
First one of these podcasts I'm recording, and really the overarching goal has been to work towards building a clinic for musculoskeletal health. And so I guess in normal terms, that's how do you treat back pain, neck pain, all that sort of stuff that you'd go to a physical therapist for, chiropractor, or some magician that your neighbor refers you to. So why don't we start by you just introducing yourself, James?
Okay, sure. I am James Leonard. I'm a chiropractor by license, sort of like a serial hyperfixator by disposition.
Okay. We'll get into whatever that means.
Yeah, but I would say like I more broadly identify as a clinician. Like I'm sort of a student of healthcare. I work in healthcare and I try to help people feel better as part of my day job, which is pretty cool.
Yeah.
And I've had the opportunity to do that in sort of a lot of different ways. I've been a clinical operator where I've managed and run multidisciplinary integrated care systems that are like largely primary care focused. So we're doing primary health, so it's like primary care, mental health, PT, chiro, kind of all working together collaboratively under one roof. I've worked in sort of physical medicine specific multidisciplinary clinics. So it's like PT, chiro, acupuncture, all kind of one roof, trying to help patients solve problems. And I currently work as a part of a chronic pain unit at a VA hospital. So over the course of my 10 years in clinical practice, I've sort of like circled the niche of chronic pain management, notably with mental health overlay, like most chronic pain seems to present itself with.
So you've got this unique experience being in, as you said, cash pay practices. Yeah. And then you were at a nonprofit treating back pain. Where was that again?
That was in the Dominican Republic.
In the DR.
Yeah.
Then you were at Amazon's Crossover Health, doing tech-enabled treatment for employers. Now the VA, and some consulting on the side. So you've got this wide-ranging experience. But before we get into that, you're a chiropractor.
Yeah.
That's interesting. And you went to the first and best chiropractic college. Walk me through how you got there. Why did you go there?
I think they all advertise themselves as the best,
okay,
if I had to guess. And it's the fountainhead, no less. I kind of took I don't think anyone takes a normal road to chiropractic school.
Yeah.
But when I went to undergrad, I knew that I was going to want to pursue a graduate degree. I knew I wanted to be a healthcare provider. I wasn't exactly sure what medium I wanted to take in order to do that. So I just took like a general studies. I did sport and exercise psychology with exercise physiology. So I just took sort of like all your general science classes. And towards the end of my undergraduate program, I started shadowing a whole bunch of different healthcare providers and kind of assumed that I wanted to go like traditional allopathic medicine, like an MD, DO route.
Yeah.
But when I started shadowing a bunch of healthcare providers, I really like looked at it through the lens of who was living the life that I was like really interested in living. And to kind of put a blanket sentiment on it, all of the PTs and chiropractors that I followed and shadowed were like really fit, really healthy, and like living like really vibrant lives, like kind of late into their clinical practice. And maybe it was just a bad showing, but a fair amount of the folks that I shadowed that were like working in more traditional healthcare roles, like MDs, DOs, RNs, NPs, they just seemed a little bit more beaten down by the system. And I was like, well, I probably want to go into physical medicine then. I was like, that makes
this
a
is
lot
a funny
of sense.
thing, because when I first met you, and ever since, you were such a happy guy.
Yeah.
You know, you treat people with complex pain cases day in and day out. And
Sure.
You're healthy, you're happy, you're living your life, you're doing a lot of things outside of work too.
Yeah.
So, wow, it was
Worked
Good
out.
decision.
It did seem to work out, and it did like. It's not to like paint like a perfect picture. I will tell you, like there are pros and cons no matter which way you take on this problem. That's the game of healthcare, specifically pain management, is just there are always competing priorities and incentives in what you're trying to do. But being able to be like active as a part of my everyday job was like a pretty cool thing to like write off as sort of a non-negotiable. And I will tell you now in my current clinical role, like I'm moving all day, every day with patients, and I really appreciate that. I think it's healthful.
Well, let me look back at my script over here.
Yeah.
How do you compare chiropractic now that you've been practicing with other modalities? That's one of those professions that can sometimes get a bad name. And I've met a lot of different clinicians, and I mean, this holds true for every sort of practitioner, but everyone's different.
For sure.
You know, I think you've got the old guard or the old ones that are like, let me find the subluxation.
Yeah, absolutely. Yeah.
You seem to, I'll let you explain it yourself. How do you view the different people in this field, compare them to other, PTs?
Yeah,
Wow.
I don't think I'm unique in this, but like I am sort of a new guard that has come into chiropractic, where I didn't really go to chiropractic school because I was particularly dogmatic about the discipline of chiropractic.
Yeah.
I actually ended up at chiropractic school because I got a rugby scholarship to go.
Really?
Playing rugby internationally after undergrad while I was applying for graduate schools. And I ended up coming back to the States, and I got an offer to go and play for this chiropractic school in Iowa. That's how I ended up in Iowa. So when I came to school, I was really interested in learning about physical medicine and how do we heal people and how do we help people heal themselves in non-interventional way. So how do we not add a bunch of extra stuff to the system and help them sort of navigate these pain or joint dysfunction conditions, whatever it may be.
Yeah.
Right? So, and I wasn't alone there. There's a lot of chiropractors that came into school with sort of the same impression. We had traditional backgrounds and we had sort of like traditional educational backgrounds, and we came to chiropractic school and we were like, oh, great. There's a lot more philosophy here than maybe I was anticipating, but cool. But when we graduated, I did a clerkship at a VA hospital. So like my first clinical rotations, I spent a year at a VA hospital right at the end of my school. So like the very beginning of my clinical practice was wrapped in this multidisciplinary framework. And it's just kind of been a part of the practice since like day one.
Yeah.
And I don't think I'm alone in that. Like I think we live in like a more and more multidisciplinary world each year. I think each graduating class that kind of comes out of these schools, whether chiropractic, physical therapy, or even like primary care or allopathic medicine, they're coming out and they're practicing in these collaborative settings. And we're just getting, I think as a profession, we are, I hope, aspiring to get better at working together and collaborating on cases to make a bigger difference.
I like that.
Yeah. So kind of became a chiropractor by, I wouldn't say by accident, but like it was a medium to be able to help like be in a caregiver role and be in a clinical role.
Yeah.
And it's interesting because there's nuance in it too. As a chiropractor, I have an independent practicer. I have an independent licensed practitioner, which means like I can be a portal of entry provider for a lot of patients. Whereas in not all states can physical therapists do that, which is something that physical therapy.
You can refer people to different specialists.
I can act.
Walk me through
I'm
that.
a physician by license.
Okay.
So I act as sort of a decision maker in the cases that I'm a part of and managing, or I have the opportunity to. And physical therapists have really struggled to gain that independence wrongfully, I believe. Like I think physical therapists, like the amount of training physical therapists go through these days is enormous. Like they should 100% be able to operate as portal of entry providers, but the system and the way the system has been designed over, the course of 50 years doesn't always allow for sort of the most capable people to be able to do the things they want to or can do when they should do them.
We're going to have to come back to that. That's an interesting point. I think I want to touch on, you mentioned the philosophy side.
Yeah, sure.
Because what I found super interesting as I've met different practitioners is I try to assess like, what are your fundamental values? What do you think the body is? Because these like really fundamental beliefs shape then what you do.
Yeah.
If you think that we're a mechanistic system and you just kind of like got to tweak it the right way, find the right drug, then, you take that sort of approach in your practice.
Yeah.
Versus if you believe that building a relationship with your client, that maybe there's something psychological even that this person, that you can intervene in. Mm-hmm. That absolutely changes how you approach your client. So if we think of, all right, we've got your client, They've
Yeah.
got this body, right? They've got bones. They've got
it's got bones, it's got muscles,
that-
ligaments.
yeah.
It's even got discs. Most likely they're degenerating.
Okay, so what is your model of the human? What do you believe that? How do you think about this thing?
Yeah, that's a great question, because like I was educated in the era of biopsychosocial healthcare, so approaching problems in patients from multiple different frameworks and recognizing like there is an emotional element, there is like a physical element, and then there is also like their social element in their life. And like in theory that makes a lot of sense, but how do you actually like treat a patient in that paradigm?
Yeah.
And I think that's something that like the professions at large have not totally figured out how we should be going about that and how we should be operationalizing, or even more important than that oftentimes is reimbursing like that care. For me, I mostly function as in pain management, and I think fundamentally like I believe pain is an incredibly personal experience for every individual.
Yeah.
And as a result, like especially persistent pain, acute onset pain, there's oftentimes like direct triggers with tissue damage. When the tissue damage heals, the individual improves. But the vast majority of patients actually don't follow that paradigm. The vast majority of patients sort of go on this roundabout journey of pain and recovery. They have an injury. They have a painful experience as a result. It gets a little better, but then it gets worse because of a secondary trigger, or because of a lifestyle issue, or because of some other stressor that maybe they can't even identify. And I think the reality is, if you want to be really effective in pain management as a provider, a lot of your job in your role is to help an individual sort of walk along that journey of reconciling both like the elements of their life that are contributing to their painful experience, but also the elements of their life that are positive and helping them to work through like the ear triggers, and then helping them sort of like navigate how do we improve the like amount of positive things that I'm adding to the equation, and how do we mitigate the effect of the negative and or decrease the negative contributions to the pain that I'm managing. And like most of my experience in like how I operate as a clinician is like helping to hold a mirror to patients so they can recognize those things for themselves, and then helping them to sort of walk that journey in their own lives.
There's so many different rabbit holes we could go down here.
Yeah,
One of
that's
them
pain,
is-
man. There's a lot of rabbit holes.
Like there is definitely what is pain, which we could go into. There's the fact that we were talking about this is pain management, which is interesting because I think when it comes to health and treatment, how you talk about it and the goals, the North Star that you're working towards really matters.
Sure.
Because one approach could be, let's get you functional, which for most people means driving your car, going to work, come back home. But what I was always so irritated by when I was trying to find help is my practitioners or doctors, like that was their goal. And I'm looking over at the athletes or the kinesiology clinics, I'm like, they're getting real treatment.
Yeah.
We really care about how they move. We really care that they feel really good and can perform.
Yeah.
Me, it's just, your hip's not broken. That little pain you've got, can you walk and are you fine? So
Yeah, I think in healthcare we're still reconciling like how to navigate the differences between hurt and harm. It's like that's a kind of a popular term that was put together by a bunch of pain scientists. But reconciling the difference between hurt and harm, and the what to do when there's a disproportionate amount of like pain from tissue damage, which like the science has been super clear for as long as I've been practicing. But I think like the study that gets quoted like most frequently was out of Mayo Clinic in 2015. There was like, they took a whole bunch of MRIs of patients that didn't have any symptoms whatsoever.
Yeah.
And turns out they all had structural problems, right? They all had degenerative discs, they all had disc bulges. And like what they found is like more important than tissue damage or like past history of traumas that the patient had. It was just their age.
Yeah.
Like basically 30% of 30-year-olds, 40% of 40-year-olds, 50% of 50-year-olds. Like it tracks based on your age. And I'm very loosely quoting those stats. But they've like recreated that study a ton of other times where they've looked at like every joint in the body.
Yeah.
And every joint kind of follows this, where there's like this disconnect between the pain experience that someone has, or like the severity of the pain that they're having, and the amount of actual injury or tissue damage we can visualize through a scan or through a test. And I think in healthcare, especially in like the modern Western healthcare sort of contraption that we've created with your urgent cares, your hospitals, your PT clinics.
Yeah.
We just haven't figured out how to reconcile that. Like, and how to like be able to have a conversation about, have a conversation, make a plan, and reimburse like treatment for someone where it's like, well, they have like a lot of pain, but like we can't really identify exactly what's going on. Or like someone that's like, well, they don't really have very much pain at all, but like they look terrible like on film. And like, because we just really haven't, the system has not caught up with the science there.
Okay, so let's go back to our imaginary clients, right?
yeah.
Joints. You've got these discs between their vertebrae.
Sure.
You've got muscle surrounding all of that.
Yeah.
So in this case, we have that like structure. That's the form of this person. But we're talking about pain, so this person's experience. And essentially what you've just said is maybe they've got degeneration in their disc. Maybe they have a herniated disc even. And that physical structural finding might not directly correlate with their experience of pain.
Yeah.
Okay, so that's a very clear insight that I'm seeing a lot of people actually knowing now. I don't know if they're in Instagram
And I'll
or
tell you,
TikToks or
in the
what,
past,
but-
in the past 5 to 10 years, I have seen a significant change in the patients that I treat.
Yeah.
Where patients will come in and they'll be like, yeah, and I got an MRI and all it showed was I had degenerative discs. And I know that's not a big deal. And that was not something I saw 10 years ago. 10 years ago, people would point at the degenerative disc and they'd be like, I need you to fix that.
Yeah.
And I'm like, dude, no one's gonna fix that. I'm sorry, like, let's try. And you're even seeing like that change. And I think the marketing and like sort of the darker sides of healthcare is not as good at like adapting. Like you still see like these curative interventional things like being marketed, but like the patients have
Like what?
I guess I can name it in chiropractic specifically. Like you do still see like these old school degenerative charts, and they're like, hey, if we get your spine moving better and we adjust that joint over and over again, we can slow and reduce the degenerative changes in your spine.
Yeah.
That's just not really a thing. And it honestly, like that impression and that simplifying the message in that way, like it kind of devalues like a lot of the actual like treatment and what you can offer as a provider. Like one of the best things you can offer as a provider is like teaching the man to fish. How do I help this person help themselves a long time?
Absolutely. But I mean, that's a great retention tool. Keep coming in for an adjustment and you're...
It is a fantastic retention tool. Yeah, it works out really well. It's deeply dissatisfying for some. But you see, but it's not just that. Like the same, I pick on my own profession because it's easy.
Yeah.
It's easy for me because I can see it very clearly through my lens. But every single profession has the same tropes in different ways. In physical therapy, it's their glutes aren't firing.
Yeah.
Right? That's what it always comes down to. Like, and it's like each profession in massage therapy, it's a super tight muscle.
Yeah.
Perhaps maybe the most correct in acupuncture, it's like a blockage of the chi.
Yeah.
You know? And it's like every profession has their sort of, well, it got too complicated, so I had to figure out like how to explain it simply, and like this was how we do it. But I actually think, and you and I have talked about this before, like earlier, I actually think there is value in a patient, or there's value for a patient in acknowledging and accepting the complexity of pain. In trying to walk that journey for yourself and recognizing, being like, hey, this is like, there's a lot of things that are playing into this.
Yeah.
Perhaps like I have these conceptual models that I can apply in my head for like, okay, this is what causes it. But like it forces you almost, and like I think this is what like really good care looks like, is like it forces you almost to start to try and identify what are the controllables in my environment, in my life, in my current experience. What can I influence? And how can I pull those levers in a way that like somehow helps me walk this tightrope out of this painful experience?
I think what you just said there is huge, like emphasizing like the fact that this person has agency over their life and over this pain. That's an incredible unlock. And for the individual, if you're able to figure out that these are different levers I have in my life, not just a practitioner, maybe it's lifestyle changes, whatever it is, maybe it's an exercise they have to do. Just the fact that they're involved, they have some sense of control, and it's not, I'm just a victim of this pain, is huge.
It is huge. And I'll tell you, like, on the other side of that, they still can opt in for care.
Yeah.
And there's nothing wrong with that. I think there's like the other side of the coin is like we totally villainize, and this was like, maybe it's a trend of a couple years ago, like it definitely happens in reimbursement. We totally villainize like the idea of maintenance care and devalue this idea of like, oh, I'm going in to get like a tune-up, or I'm going to get this like worked on. The payment model is totally villainized that as something that was like, oh, well, that's bad care.
Yeah.
Like, I don't know, if the patient wants it, if they have perceived value in it, and as long as you're framing the care in a positive way, where it's not contributing to the like or decreasing an individual's level of self-efficacy. Like, is it bad for someone to want to go and like every once in a while get like a movement screen to make sure that, hey, like, am I like moving optimally? Am I doing as well as I could? Is there ways that I can continue to like unravel this onion that is life as a physical being, like, and be better?
Yeah, no, I'm for that. I think that's great. If you can afford it and if you have the capacity to do that, as long as you understand that there's room for that as like a supplement to your health and healing. But for the people that are kind of confused and they're stuck and they really need help and they're caught in these like, keep coming in.
There are plenty of patients. There are plenty of people suffering. Like, it's not, I think it's a matter of like providing avenues and options for care that like allow them easy on-ramps.
Yeah.
And then, and I think here's the other thing that I've really learned as working as a part of like collaborative care teams is the reality is sometimes someone has to hear the same message multiple times from multiple different sources before it's something that actually sets in. So as long as you're framing your message like positively in a way that like someone can find agency in their pain management, I think it's great. Like, even if the patient opts out and is like, well, I don't know, I really didn't like that guy, like, it didn't feel like he had much to offer. Like, maybe I'm number 3 in line of the person that explained sort of the fundamentals of pain to them, and maybe it takes 10 people to tell them that before they can sort of find that agency and feel more empowered.
Okay, so what I want to think about now is this clinic that I intend to build.
Yeah, I'd love to hear about. What are you trying to do, man? What's the fundamental North Star for you on this?
Yeah, I feel like there's a few North Stars. It's all really inspired by my own experience of having pain for a while, running into so many just terrible experiences, and a few good ones that have shaped me. I mean, they've fundamentally shaped me. And the question here is, let's narrow it down. Let's go to MSK. Specifically, let's think about low back pain, neck pain. If someone is experiencing some sort of pain and it's gotten chronic, they've got this like ache in their lower back or it's in their neck.
Yeah, we're talking persistent pain syndrome.
Persistent pain. If someone's really trying to figure out, what do I do? I'm kind of at a loss here. What could the ideal experience look for that person to recover? That's a wild question to ask because that's not generalizable. That experience for that person depends on their own preconceived notions about pain, their body, what actual causes they have, what symptoms they're presenting with. But the whole concept here is if we ideate about this clinic, this person can go there. They can get a really high quality assessment that actually understands what's going on with this person.
Yeah.
Not limited to one modality, not limited by whether we're dealing with payers or cash pay. Just like in La La Land, what could that assessment look like? And the way I really think about treatment is you have an assessment and then you have your levers you can pull on, your interventions. And then it's a cycle. Right? Yep. You've got this model you develop of the patient, potential hypotheses about what's going wrong, let's intervene, let's test. So that's what I want to figure out. How do we best assess a person? What interventions do we have available? And then there are other operational questions that come on top of that.
Yeah.
But let's start there. Assessment, just briefly, high level, what are like key things we need to look at? How do you go through that? Because, I mean, you see a person, I'm sure you're already like drawing some conclusions and then figuring out how you want to talk to them.
It's a great question. First off, I think that's very cool. I think this is like a valiant and worthwhile way to spend time because the current system does not.
I want to tell my mom that.
You should tell your mom that for sure. I've just seen I've seen the system through a bunch of different lenses. And what ends up happening, for better or for worse, is every clinic eventually becomes a reflection of its reimbursement strategy or its reimbursement protocols. The payment model drives care, full stop.
Okay.
Almost always. And no, full stop. And I've seen this in every vertical that I've worked in. There's, in your cash pay payment models, your customer acquisition and your customer service basically dictate the entire care plan that you're going to put together from there. Yeah. You're a service business at that point, right? Your insurance-based payment models are going to be totally based on billable services per square foot. Okay. It's what service lines can I put into this space that I can bill this insurance company at this designated rate? How do I get the most money that I can out of these individual square feet? That's why you get these ambulatory surgical centers popping up. They're very profitable. It's why you get imaging centers popping up all over the place.
Yeah.
Because it's a billable service. Imaging makes a ton of money, right? It's why physical therapy as an industry is shaped the way it is, with this 3 times a week for 36 visits. It's because it's predictable cash flow. You can build a really good business around. It's not that it's necessarily the ideal care plan for folks. It's just predictable money. Okay? When you start getting into your direct to employer, that's where you're saying, hey, how do we subsidize some of these billable services? Because we want to optimize for a different outcome with our patient population. We want them to be overall, we're willing to put more money up front, but we want them to be less expensive. We want them to engage in less really like outlier expensive procedures, right? So we want them to optimize like for less cardiovascular disease disorder, less hospital admissions, less unnecessary imaging for low back pain that invariably escalates their care too rapidly. And that's where you get these levers where it's like, okay, well, why don't we build our own primary care system and we'll tie it to an employer, and the employer will subsidize it with insurance payment. But they're essentially subsidizing for a concierge experience in order to make that the first access point that a patient goes to, instead of opting into like a specialist out the gate. But the reason why that happens is because for that employer, they're hedging their bet. They're saying we're going to pay the money up front because it's going to save us money in the background. Okay. For a nonprofit, obviously it depends on where they're getting their money from. If it's grant funding, if it's like donor-based funding. But a lot of like the nonprofit world is built on this idea of like, we have to deliver these services, but we have to promote our delivery of these services in a way that like increases our donor pool. In the VA, like the VA largely operates in like a risk shared, like, or a managing the risk of the umbrella of patients that they're taking care of. They have a set population. They have set dollars to do it. They have to figure out how to engage that population with the care that they have on staff in a way that like basically just doesn't break the budget. So like naturally there they run into like care rationing elements where they're just not able to deliver all of the services to a patient all of the times when they want those services, because like the system just can't afford to operate under that mechanism.
Fascinating.
The reimbursement of the system that you are building so frequently dictates and determines what type of care actually gets delivered to the patient at the end of the road.
Yeah.
In chiropractic specifically, I'm going to give you a really deviant one here. Specifically, like for Medicare patients, E&M codes, evaluation and management codes, are not reimbursed by Medicare for chiropractors, which is why you don't see more chiropractic clinics setting themselves up as like evaluating and management-based clinics. They don't set themselves up as physicians. They set themselves up as we deliver adjustments, because that's the billable code. They get paid for the 3-4. They get paid to manipulate 3 to 4 regions on a spine.
Yeah.
They don't get paid to do a really good workup and say, hey, I'm actually not the most appropriate care for you today. The reality is your blood pressure is a little high. I need you to go over to your primary care doc and talk to them. I don't get paid for that. So like the business, and providers still do it because it's the right thing to do, but the business isn't set up to do that. It takes the provider going above and beyond and doing a really good job to actualize that model of care.
And you called that what? Evaluation and management?
Yeah, an E&M code.
And is this like
Whereas,
a CPT code?
Yeah, your CPT
That's what
codes.
that is? This is fascinating.
And
This is like making me go through so many of my experiences with chiropractors where it's like,
Get on the
hey.
table, let me adjust you.
Yeah, and I'm like, dude, take a look at me.
Take
They do, which is great, because I've met some incredibly like, wow, you have a deep understanding of anatomy. You really know what you're looking at here. But let's do like
Got to get to business.
let's do the adjustment. Cool, come back.
Yeah.
Let me know how it is.
Let me know how that goes. I'll see you when you come back in. Yeah. It's how the code's kind of set up. Whereas like in the VA, there's been the chiropractic sort of contingency that is in the VA has set themselves up to aspire to do more than that. So doing comprehensive evaluation and management, doing like proper, like how do we manage this case long term? What other modalities can we integrate into the care? How can we empower these patients? And like as a result, like those chiropractors in the system have largely self-selected to be in the system. It's been very competitive. It's mostly very competitive to get into the system, but they also like publish at like a very like disproportionate rate to their other colleagues because they're just kind of, a lot of them have academic affiliations.
Okay.
I'm not one of those. I'm just a regular chiropractor in this system.
This is actually kind of the core of a lot of the stuff I'm researching right now and trying to understand, because it's how do you align incentives?
Yeah.
And I think I've understood this intuitively, is this is where you focus. Prior to me wanting to start a clinic, I was starting a chair company.
Yeah.
Because the whole thing was like, all right, so do you want to go be a doctor? No, I don't want to spend a lot of time in school. How can you deliver results to people really quickly? And where's a system that matters?
Yeah.
Consumer. Because all you care about is, does this person want this thing and do they like it? Because if they like it, then they say good things about it and they might buy it again.
Yeah.
And obviously that doesn't fully translate to medical care.
Sure. It does kind of translate into, like you see in the cash model, like you see these like emerging almost like package type comprehensive care programs, like concierge care that you see, like Peter T is, you mentioned him earlier, like is a super famous example of like someone who's like, I'm going to take your case on. It costs this much cash up front. That is the buy-in. That is like the direct primary care does this in kind of a different way with like the subscription model, which like that is the buy-in. Mm-hmm. And now let's go ahead and figure out everything that you need and what you need and how you need it.
Okay, so with the strategy for this clinic that I'm proposing, let's just rule out some things. Not going to work with employers to start, okay? Slash that out. My personal feeling is that building a cash pay practice aligns incentives the most at the beginning because it's really about how do you provide an incredible experience for people? How do you genuinely serve them? And because it's cash pay, there is more room for a direct relationship between the clinician, the practitioner, and the client.
Absolutely.
Because you do a good job, you're paying me. You're telling Katie, Susie, and Barbara about me. Mm-hmm. You know, that's good for my name, and I get paid.
Yeah.
I'm not thinking about, what's that other sort of entity over there going to say about what I did today, and are they going to give me money?
Yeah.
But, of course, the drawback is it's expensive, or at least more expensive than,
It reduces your pool of effect, right, in some ways. Like, it limits, to an extent, like, the folks who have access to the service. But I don't know. I think it's the right way to do things, especially if you're trying to do something from an experimental perspective. I think going cash pay is an excellent way to operate out the gate. I'm a huge fan of the DPC, like direct primary care route. I advise everyone to get a DPC after the age of 50. You need to have a physician who's solely on your team and not anyone else's team.
What is a DPC?
A direct primary care provider.
Okay.
So the one medical model essentially is like probably the most like prolific that exists, but there's a lot of independent DPCs out there as well.
Okay.
Largely being a part of a healthcare group or healthcare org that you as a consumer are paying money to for them to have your back and solve whatever you have a problem, you can access them to help them.
This is opposed to like an employer-based insurance?
So Crossover Health, who I was a former employer, they operate like an analogous model, but the employer pays for it.
Okay, because I know that one of the biggest issues with payers is just the expectation that you're going to churn every 18 to 24 months.
Sure.
So can you get a DPC while being employed and having your Blue Cross Blue
Yeah,
Shield?
it's a cash pay service that's like above and beyond.
What's cash pay?
Yeah.
Okay, gotcha.
That's above and beyond like your standard insurance plan.
Interesting. I'll
Yeah.
have to look into that.
Yeah,
That's a good model.
I think it's the right way to navigate healthcare in the current world that we live in.
Okay, so this segue started with a question about assessments.
Yeah.
I'm kind of getting annoyed sitting down here. We should walk around and talk about this.
I'd love to walk around.
Yeah, let's do that. Rahul, do you think that's possible?
Yeah, let's do it.
Is this be that guy?
Look at that.
Is it edible?
Anything's edible once.
All right.
I don't know how that's going to work out for you.
Yeah, do you get a lot of mushrooms in your compost?
Mycelium is a very important part of the compost, it turns out. And the whole everything. Mycelium is all around us all the time.
Mushrooms guy, aren't you?
I like mushrooms a lot. Yeah.
We'll cut that out.
Yeah, you know what? I think they're very good for the world.
Oh man, it's so pretty out here.
Yeah.
So let's see, where were we?
All right. You're going to build a clinic system, and you're going...
I will with a lot of help.
Yeah, but you're starting, like the foundation in which you're starting this like journey is like, how do I make the biggest impact for that individual who has pain?
Yeah.
And you're trying, and from what our conversation's been, it sounds like you're trying to peel back sort of a lot of the structure that has been sort of like implemented because of the systems that are healthcare. And you're trying to pull that back and basically say like, okay, but what just makes good care? And how do we like do that and deliver that to individuals in like a really meaningful way?
Yeah, there's a systems part of it, which we talked about, the incentive structures, blah, blah, blah.
Sure.
The other side of it is people have different views and approaches to treating the body. I've met some like crazy somatic practitioners. I've been to India and met yoga teachers.
Sure.
And then I've met like incredible like biomechanists, right?
Yeah.
So everyone has a bit of a different philosophy, and now that I've talked to enough of them, you start to realize how they could fit together. So that's a big thing I'm thinking about as I talk to people that come from different perspectives, but are focused on the same fundamental thing. For the most part, I guess I'll address that.
Yeah.
What does it look like if you have people working together to provide the best possible care? And I think that starts with understanding what's wrong with the person.
Sure.
So in my head, that's assessment.
Yeah.
What's going on here? Let's get all the information we need. And then it's a cycle of treatments and then reevaluating, blah, blah, blah.
That makes sense.
Yeah, what is your perspective on that? You see a patient, they're coming in. How do you go about this?
All right, I've got a couple takes. First off, I think it's cool. I think it's like really important thing to try and figure out. But I think like I've become less dogmatic about my assessment and the way that I think about like breaking down what the actual problem is with the patient. The longer I've done this, I certainly like have my treatments and like my go-tos and the things where I'm like, okay, this is like the way that I think about managing a patient. But I think the reality is all these treatments exist because they worked for somebody. Like it's like there are very few treatments that either of us have ever heard about that like have never worked for anybody.
Yeah, that's a good point.
And I think that's why like navigating like the advice environment, particularly online, is so challenging because pain is so personal and people have like a lot of emotion, not only towards like the experience they're having with the pain and the damage or the issue that they feel like they're addressing, but also with like what type of treatments they've had or are going to get, right? People don't talk about like, hey, you should go get surgery. They say, hey, you should go see my surgeon.
Yeah.
Yeah. And you hear it like real, and like surgery is like a wild one. You'll hear folks be like, I've seen the surgeon 5 times.
What are you doing?
I mean, I don't know, man. If you had to do the surgery 5 times, it's like...
He's got great bedside
Yeah,
manner.
is that the best surgery? Like, I want to do it once if I could.
And I think we both agree that there is room for these sorts of invasive procedures.
100%.
Not everything is like an adjustment or a psychological intervention. These are very valid things, but
100%.
be measured.
100%. Like, and that, I think that's the reality. It's like every intervention, even our most extreme interventions that are out there, like they exist in like are pervasive and are convincing because like they've helped a lot of people. But the approach that I think is important to take, and I think the research generally supports this, is like it's called a stepped care approach to care, which essentially is like, the reality is for most interventions, we're not really going to know whether or not it's going to help someone until after we've done it. So how can we expose and help that patient navigate a bunch of different first line, minimally invasive, generally less expensive, and reversible treatments before they start escalating care? So how can I, and then finding ways, and I think this is going to be the nuance of like what would be cool that you have to figure out, is like finding ways to help them partner with providers that they are very drawn towards. They feel like this person or this intervention is going to be very helpful for them. Because that's a huge predictor of successful outcomes. Does the person like the provider they're seeing? Do they believe that the treatment they're going to do is helpful for the condition that they have? And do they like generally like the environment that they're in? Like, so being able to help people navigate and say like, hey, here's a suite of treatments that we have available. They're all done by the best providers that we have, that are in the market.
Yeah.
We have the best PT. We have the best somatistician. We have the best yoga instructor. We have the best chiropractor. We have the best acupuncturist. What feels like a good first step for you? And then helping them to go and basically navigate those types of treatments.
I completely agree. I think what I want to get at here is, and I agree, it's not good to be dogmatic. And I think everyone that kind of gets into something like this, you like latch onto something like, oh my God, this is the solution.
Yeah.
Like, this is so impactful. And then you come across something else like, oh, this is...
Yeah.
And then now that I've been across like a come across enough different interventions. I'm like, okay, everything has its place, and you got to be really measured and understand what's the best. The point is, say we have this suite of every sort of intervention possible. How do you accurately, or to the best of your ability, direct this person to one of them to start? You mentioned that you want to try things, test it out, see if it did anything, sure, but just off of an assessment, off of you looking at this person, palpating them, maybe doing some testing of some sort.
Sure.
How can we gather the information? What information would you gather? And then how do you decide this intervention first or this one first?
Yeah. I'm excited to see you figure that problem out. Okay. No, I think it's clear. There's a couple things that are clear that you shouldn't do, right?
Yeah.
That maybe are intuitive for people. Like, the evidence is pretty clear that you shouldn't overly medicalize these conditions out the rip. So you shouldn't go and get a whole bunch of scans, whether that's X-rays, MRIs, CT scans. It is a fool's errand to try and go deep down the rabbit hole of let's identify the specific tissue or structure that is causing the problem.
Okay, interesting.
The evidence is extraordinarily clear on that. Essentially, the idea, because going down that rabbit hole and being able to demonstrate to someone, like, hey, you have this damage on this scan or this MRI, and as a result, you're probably having this pain. The impression that the patient can have through seeing that problem, it can have negative effects in their long-term outcomes.
I had an MRI, and the doc found herniated disc, L4, L5, and then herniated disc in my neck, which I was like, I didn't even know that could happen.
Sure.
And so then I'm like, is this reversible? And they're like, no, not likely.
Yeah.
And so then I'm like comforted by the fact that, hey, my pain is real.
Sure.
But then there's that deep association with, wow, this is what's happening. How do I even fix it?
But I think, and that is like, you're changing the question. You're changing it from how do I influence the pain that I'm experiencing to how do I fix the structural problem. And those two things are not always connected, or they're not perfectly connected.
Yes.
So here's you have to come back to, pain is a great motivator. What is that pain keeping you from doing? What is that pain making you do? What is happening? How is that pain affecting your life?
Yeah.
That's what brings people in for appointments. It's not the just simple experience of like this hurts. A lot of times it's like, this is interfering with something in my life that I would like to be doing. Or maybe it's like making me take more breaks that I feel like I shouldn't have to take because it's bothering me a lot. Can it help me address this? I think that's a really important thing to try and nail down with your patient.
Yeah, that's a really useful, distinction you just made, because you have pain, but then we have structure. And I think the thing is, what I'm getting at here is, if you're just trying to make your pain go away, that's one thing.
Yeah.
And I guess it's good to articulate that for some people, their goal is, let's take care of this pain, but also I want to perform better. I want to actually optimize my structure, my posture, whatever.
I want to go get treated by the kinesiologists because they're doing real treatment.
Yeah.
Right? They're doing training.
And I think this comes down to what are your goals then?
Yeah.
Yeah, maybe you're coming to this clinic because you want to get rid of some pain, but subliminally or subconsciously, you really do want to look really good and have this sort of structure. And so maybe you're not satisfied with this intervention that is going to just get rid of your pain.
Sure.
Maybe that's something else that you do want. So I guess this is making me think that in the assessment portion, as you're doing an intake, you want to really understand, what is this person's
what's driving
goal?
them, and how is the pain interfering with their life and the things that they want to do.
And part of having good clinicians on staff is making sure you can address those different things.
Sure. Yeah, absolutely. And figuring out, I do think we think about treatment and we think about pain management in a single episode as patient presents with problem, we fix problem, we discharge patient. But as we've kind of been talking about this whole time, pain is it's a journey, man. It's a very personal journey. Even your experiences, you're talking about how you've navigated care and it's taking you on all of these different roads. I mean, now you're building a clinic, right? Pain has been an incredible journey for you in the way that it's motivated and made you navigate your life. Well, it is to some degree that for every person who experiences that. Every person who's ever been alive is going to have pain at some point. So it's really about what do I do in this chapter? What's the treatment that I do? And a lot of times the value comes from actually not getting dogmatic, but being invested in an individual intervention.
Yeah.
I'm going to go do, the patients that I see do the best are the ones that are yoga's it, man. I'm going to go do yoga. And they go do it. They go to, maybe they go to India, sure. But maybe they just are I'm doing this.
They're committed.
Freaking 2 days, I'm doing it every day. And every day means 3 times a week, you know, but it's like I'm doing this every day. And those people, although they feel like, okay, this is my new normal, it's normally a chapter. It's like I'm doing this for a while. Even and this is something I've really noticed as a clinician, is I have a lot of patients that identify as like, oh, like James is my chiropractor. I see him all the time. And what it ends up being is like, they see me really intensely for like a couple months, and then I don't see him again for like 2 years. And then they come back and they're like, oh yeah, I go to the chiropractor all the time.
Yeah.
And it's like, do you? If you actually look at it on a graph, like it's like, you go like for episodes.
But they're committed.
Yeah, they're committed when they're there.
Okay.
And I think that's important. I think you should show up, like going to one physical therapy appointment, even with the best physical therapist, is probably not going to make a big difference in your issue. But going through a trial and actually trying to unwind whatever that layer of the onion is that you're navigating with your problem.
And I think it's really trying things and being open to experimenting with whatever that is with full commitment, and then coming back and honestly reevaluating.
Yeah.
So if your clinician practitioner is able to actually acknowledge and guide you through that and make you feel like, hey, like, let's do this. I'm going to support you through this. If it doesn't work, let's assess and like think critically about this, instead of, I've found a lot of places where it's like, you do this, you do this.
Yeah.
It's like, where's the thought?
It makes a lot of sense, man. And I'll tell you, it's actually in line with like the pain neuroscience education, which is something that like you're really digging into, which is this idea that like, if you can understand pain more intimately, like understand how it operates, why it happens, like what is the physiology behind it. If you can understand that, there's therapeutic value in that.
As an actual like patient?
As an actual patient, as a treatment, as a form of treatment. The studies that have come out on that, like the original indication on those studies were like, well, we're going to do this treatment, and I expect that patients will improve. They'll get better as a result. And what they found, like the latest sort of course of studies that have been coming out, is like the numbers on their pain scale don't actually change very much. Like they still experience pain, but their reported suffering actually decreases a lot. So it's like the pain may still be there, but like your relationship and your experience with it, because you understand it better, actually improves.
Yeah.
Which I would extrapolate that and push that to say like, hopefully that affects your quality of life. I do want to hit this note on imaging.
Okay.
Because I think it's a real thing. Like intuitively, it makes so much sense that like the most advanced and best care that we can possibly provide is going to be like the most technologically advanced and capable. Let's run all the tests. Let's get all the screens.
Yeah, and that's where like the functions, the pre-nuvos, they're doing great.
They're doing really well.
What do you do?
Well, it
with
makes
that?
sense. Because it makes so much sense. It's super, super, super intuitive, right? I can look at that image. I can see every little thing that could possibly be wrong with me, and let's just go fix that thing. But that's like just not what the evidence shows, man. And like for someone who is like has like really strong sense of self-efficacy and like a great support system, and like generally is like an athlete or like has like an athletic background, like sure they can look at all those like normal variances in their MRIs, and it's like it doesn't really affect them. But for someone that has like a predisposition for chronic pain syndrome, like they look at an MRI that's got a whole bunch of jacked up stuff on it, and it like could fundamentally alter the way like their life. Like they could cause like actual problems.
That person's going to be depressed and anxious if they already aren't.
Sure, they're gonna get in like who wouldn't, and I can totally understand where it comes from. Like, they might get fixated on trying to fix this structural issue. Like, it's almost like an eating disorder. Like in the regard of like you're trying to like fix this like you're trying to achieve this ideal of perfection that like isn't actually tied to like a successful outcome.
I was definitely caught with that for a while because it just once I was injured, I didn't know what it felt like to be normal. So I didn't know what I was moving towards, and that was really difficult. Because the only thing that I could wrap my head around is there's a structural problem, and I can imagine what maybe a non-herniated disc looks like on imaging.
Yeah.
And so it's like easy to cling on to, because otherwise it's like now I'm asking weird philosophical questions of what does it feel like to be really great?
Yeah. And what was that like? Was that like, it sounds like that was like almost a negative experience for you, or did you end up like framing that, because you went on like a yoga journey, like did that end up becoming a positive experience, or was it just kind of?
Well, that's what sent me down this whole thing, because I was hit by a car, and so then my whole sense of like left and right and how I felt normal in my body was gone.
Sure.
It's just now I have pain in these places. I don't even know what it means to stand up straight. And the difficult answer in how I approached that, which ended up working but I would not recommend, is let me deep dive into understanding how my body works. So then I'd like fully feel out the different muscles of my legs.
Yeah.
That I was so concerned with. And then once I was able to get them to like their end range of motion and back and be like, oh, I can fully move through this. This is normal. I had to like fully understand what is possible with this leg. How can I move it around? And then I developed a sense of comfort in my body and I could be like, I trust this thing. This is normal. Because I can feel it. I know what my leg is. I know what my psoas is. I know what my abs are. These weren't things to me before. They were just.
You are the textbook patient, dude. That's exactly what's supposed to happen.
But
I mean, fundamentally,
tough, man.
Yeah,
it's tough.
It's not easy to do it by yourself, but fundamentally, like, that's a big part of what makes the professions of chiropractic and physical therapy, and more so, like, I think physical medicine as like a whole umbrella, like, successful, right? It's not so much like the specific exercises or the specific adjustment that you get that makes like the difference. It's like it's the reassurance that you give to your nervous system when you take it and you challenge it to go do something and it doesn't cause more harm. Yeah. And I think that's like on a fundamental level, like that's a lot of like why these treatments work. That's why like they all boil down to movement is medicine, which is essentially like, I don't know, man, like just move that joint and like chances are it's gonna get better. And like in physical medicine, man, PT and chiro, we get so dogmatic again about like what type of movement. I was trained like with the McKenzie assessment, which I really love. It's like end range loading. You take a tissue to the end of its range of motion, you return to neutral, and you kind of do that repetitively. I was trained in that and I really, really like that assessment because first off, you feel like a wizard sometimes at the way that you can reduce pain, but secondarily, because like it's so reassuring to patients. Like it shows them that like they can do things without causing harm, and like that in of itself is like the treatment. Yeah. And I think that's like there's something like really like it's like cool about that.
I think you just very neatly summarized what actually helped me. It was feeling safe and being able to just understand for myself, can I go through this motion without feeling pain? Yeah. And if so, can I do it again and kind of figure out how to do it without pain? And then
there's a book called like Fix Your Own Back. Robin McKenzie wrote it. Maybe you could write like a different version of it.
There's enough books out there. We've got Back Mechanic, we've got Healing Back Pain.
But Stu McGill, and that's actually like a great point. Like Stu McGill and that like whole mindset is all about sort of like building stability in neutral. It's like how do we, and I may be summarizing if there's a Stu McGill expert out there, maybe. I'm sorry.
We'll talk to him next.
I'm sorry if you disagree, but like as far as I've come to understand it, in like a lot of the core bracing mechanisms are like we want to build strength in a neutral position because if we feel strong and stable in our base, then it makes us more capable of going out of it without causing problems.
That, and I feel like if I were to get really funky with it, you could draw so many parallels to, I don't know, psychological frameworks. Feeling comfortable and neutral and
100%.
The confidence to do stuff out of there.
Another framework I've trained in is called foundation training. It's great for low back pain. A guy named Eric Goodman put it together. Dude is really good at putting a system together. But like essentially it's all about strengthening your posterior chain. So basically saying like, how do I make the muscles on the back of my body stronger? If the muscles on the back of my body are stronger, they're less likely to get damaged when I do physically active things. But like, why do all of these things work even though they're fundamentally built on like different principles? And it's like, because it's just movement. Like at the end of the day, it's like you're encouraging a patient to move their body and to go through like movement in a thoughtful, like a thoughtful and I guess more important than thoughtful, intentional way. And then you as a provider or as like an instructor are reassuring them that like, hey, if you do this, it's probably going to help. And it's helped a lot of other people like you. It's like that in of itself is like really therapeutic.
Yeah, you just summed it up. That's what helped me. I mean, you get that haircut, as you put it.
Yeah. You get an intervention that's like easily accessible. Yeah. And so in my current role, I'm a chiropractor at the VA, right? So I'm a role player in this system, and my role is that of like a chiropractor. So people come to me with an expectation of what treatment is going to look like, and like I kind of feel like it is my responsibility as a person participating in the system to like meet that expectation.
Yeah.
Right, so when a patient comes to me, I do a chiropractic assessment on that patient. Like, I evaluate how each one of their joints is moving in comparison to the other. I do my orthopedic and neurological exams. I evaluate their their overall range of motion, and I look for like discrepancies in that.
Is that like left-right asymmetries? What do you mean?
Yeah, I'm looking for like, is your flexion, like, are you limited in flexion? You get pain. Where do you get pain? Are you limited in extension? You get pain. There's a textbook called Guyton Physiology. It teaches physical exam. Basically, every profession uses the same physical exam. So the orthopedic, like this exam is pretty standard across disciplines, no matter what you're doing. But for me, as a chiropractor, in this role, it's my job afterwards to be like, okay, well, what does a chiropractor do with that information? And I go through and I do adjustments. So I basically help to improve asymmetry between joint restrictions, and I teach patients exercises that like basically help, like most likely help like guide their current conditions and issues. And I do like stretching and soft tissue manipulation, basically whatever the patient needs, but like whatever falls under my chiropractic umbrella, right? But well, I'm not going to give them, I can't prescribe them medications. I'm not going to give them injections. I work with a lot of physical therapists, so it doesn't make sense for me to be the person doing like one-on-one intensive guided exercises, because like it would make more sense for me to refer in that situation to someone who is like, that is what they do. Yeah. So in this system, I do all of that, but the chiropractic adjustments kind of, they provide, not only is it like intimate, right? I'm touching someone, so it like creates a rapport, but it provides an opportunity for me also to like have a conversation, figure out some of these higher level things that we've been talking about today, like what's actually motivating about this pain that person has. And then try and help come up with a strategy with them over the course of a couple treatments, because adjustments almost always have temporary relief of symptoms.
Yeah.
Well, how can I like use that temporary relief as a window to be able to have a broader conversation about the things that are happening in their life that are contributing and causing issues?
So I don't know many people that actually do that, like that specific aspect that you're diving into this person's life and what else might be going on. It's so therapeutic.
It's very therapeutic. It's not reimbursed. It's not reimbursed. And I think maybe this is an important like piece of it, is like that is a really, like maybe in your clinic, like structuring that conversation in like a really formal way, but also like holding that thread as like a conversation that happens across individual disciplines. Like, so the whole care team comes into that appointment and says like, okay, this is James. James has lower back pain. James is really interested in navigating his lower back pain because he really likes to ride bikes, and he kind of gets a little weird about it. Like, he likes to ride bikes like really far. And he wants to ride bikes like really far. Like, how do we help? We know that's like, getting him back to like, okay, his back pain doesn't bother him a lot isn't totally like, that's not his goal.
Yeah.
His goal is like, he wants to ride this bike like way further than he should. How do we get him there?
And bringing everyone in on that conversation so that there's that clear transdisciplinary communication, as you put it.
It exceeds interdisciplinary care, man. It's transdisciplinary care. That's exactly it, man. So all of the disciplines are working together to try and basically meet that patient where they're at and help them figure out what they need to do in their life to address and solve that problem. That's it, man. That's healthcare. We just figured it all out.
God.
Yeah, I think that's all you have to do. Now you gotta figure out how to pay for it.